Okay, so first of all, I would like to really thank Professor Hazibullah WAIZY. We work together since now, I would say 3 years. He's a very good surgeon, especially in MIS. So it was an honor to be able to work with him. So we first met during the GFFC in Munich in December 2017. So the team was so from people from Newclip and from WAIZY and Stefan Egger from the CEO of Newclip Germany. He came to us with a simple idea. It was to develop an implant to be able to do MIS, to be able to do a closing wedge osteotomy, but with having a very strong construct, a reliable procedure, and to be able to do it through MIS. So we started in 2018 with the first prototype, and we wanted to put the plate on the dorsal part of the first met. So to do the closing wedge with a burr and to insert a plate to lock the first met. We did the first cadaver lab. We saw some issue. I mean, we had to do a longer plate because the screw was a bit too small. So we reviewed all the design to have something longer. We also started to design an external guide because the goal was to be able to bring the plate under the skin and to manage all the holes and all the screw insertions through the guide. So to do the surgery through a very, very small approach. We did the first prototype in January 2019. We had good results, but during the surgery, we have seen some issue by putting a plate on the dorsal part of the first met. We have seen some elevatus, so we said, okay, let's do a plate to protect the hinge and to avoid any elevation of the first met. So we designed a new plate for the medial part with a screw crossing the cut to have something as strong as possible. We had the first prototype in June the same year. We did the very last cadaver lab in France with WAIZY. And then we did the first surgery. So at the end of the day, we designed a new plate, something very new you cannot see on the market, to do closing wedge osteotomy in MIS, providing something very strong and with a reliable construct. I mean, in the guide, you will be able to do all your holes, all your screw insertion, and also you will have a care wire just to make sure you have the good positioning under the skin. So thank you. It was a pleasure for me to work with WAIZY on this project and with the whole team. And thank you very much for your attention. And now I will give the talk to WAIZY. WAIZY, if you want to share your screen.
Just a minute. Thank you, Arthur, for the warm welcome and the nice words. I think it's a hard day now for a lot of people of us. The virus stopped a lot of normal works and normal things where what you're thinking about and your daily work. And I'm happy to going back to something normal, thinking about plates, thinking about pathologies and hallux valgus. It's maybe some part of back to the normal life, and I'm really happy to have Newclip here, and you supported us and me, especially me, a lot about with this project. So, minimal invasive bunion osteotomy. Something about me. I'm just changed my workstation. I'm now in a private sector working. I used to work in a clinic and did a research about that. But we are going to minimal invasive surgery. my first contact was about more than 10 years ago or 12 years ago in Italy. And the first, I was very critical, and I published this and about some cases. I did a retrospective analysis, and to be honest, this was not MIS surgery. This was more a bush osteotomy we looked after, and I was not happy. But by the time I changed my mind, I see patients, I spend times in hospital with fellowships, and this is the same thing that a lot of people know. We know minimal invasive surgery. A lot of people are happy with that, and we have really good studies now. If you only look to the publication, we found, if you just put in minimal invasive foot surgery in PubMed, you see we have a huge amount of studies now. And if you look to the foot, we have the typical pathologies, and I think for mainly of them, we have good MIS solutions. For example, the hallux rigidus, if you put type 1 or type 2, you can do osteotomies, you can do very good cheilectomy, and the studies are really clear about that. So cheilectomy is a good thing to do it in MIS way. If you look to the metatarsalgia, I used to do a vial osteotomy. I think a lot of people of you also, but we know about the problems of the vial osteotomy. We're bringing in a non-articular pathology to an intra-articular osteotomy with the vial osteotomy. We're going to the biomechanics and change them. With the DMMO, we have different approach, and the clinical results and also the results in those studies we already know, they're really good. We have less stiffness and a definitely better outcome for the patients. Same thing for lesser toe deformities. Now we are not forced to do arthrodesis or do a arthroplasty of the joint. It's a more cosmetic benefit for the patient and a functional benefit. So this is not new. I think you all are in this session now because you have experienced MIS surgery, the bunion surgery, or the smaller bunions, the talus bunion, definitely a part of the MIS surgery, and also the calcaneus osteotomy. 2 years ago, we published a paper about that, and we have good bony healing. That's not no matter. It's also an open surgery, but we have less. We had less problems in a neurovascular view, and also wound healing was better, and less radiation in patients with the MIS surgery. So in the end of the day, the holy grail is still there, the hallux valgus. So we have done everything, but the main pathology, the main thing is still a problem maybe. If you're going back to the typical ways we could address the hallux valgus, we have a lot of operations, and the operative techniques did not change so much. What changed is we have new implants. We have a huge development in implant technique. We have headless screws. We have locking plates. So different techniques in fixation of the first ray. Going back to MIS surgery, we have the first generation osteotomies without really osteocentesis. The published results were good. Also, the bush osteotomy, which is not really MIS surgery, is a mini-incision technique. But we have in the last years by Benoit and Redfern and other colleagues, we have published good results about that. But I think we already know also some of problems they may occur. It's a high demanding surgery technique. We have a learning curve. We have patients with shortening and some other things. So we are not at the end of the line. We have the proximal closing wedge osteotomies, good technique, powerful. We are proximal. We have a high potential for correction, but the osteocentesis with one screw, if you break the hinge, you are in trouble. You don't have the rotation stability. The results, if it works, if your osteocentesis is okay and is stable and you have a good correction, achieved a good correction and the bone healing is fine, they are good. But in my hand, I'm a little bit frightened. If I do that, the people are not allowed to do full weight bearing by only one screw. So we have different techniques, MIS surgery, and going to the literature, we have some studies about that from 2017, 18. So no really 3-4 years old studies, and the main thing is we have complications. If you look to this review, we have dorsal malunion in 70%, recurrence in 40%. If you use osteosynthesis technique, they are weak or no osteosynthesis. So this should be, a focus should be there. And the end of the day, it means if we do hallux valgus osteotomies, joint preserving techniques, we need a stable osteosynthesis. I think this is clear. And in my view, my problem was I have the nice things of MIS surgery. All this less soft tissue damage, less swelling, less stiffness, a good post-op movement, a good functional positioning, but I have weak stabilization, less weight bearing, long rehab, all the points that are strong and powerful in open surgery, I have to lose them to doing MIS surgery. I was not happy with that. So we talked about that, and we thought we should combine them. We should bring them on one side. We have to combine the benefits of open surgery and the benefits of MIS surgery together. And this is the reason we are now here and to show you those things. So let's go through this patient. We have the right foot, hallux valgus, and also hammer toe. And this is all I need for this surgery. We have the plate, we have this very nice drill guide, which is outside the skin. We have the key wire holes where you can fix the plate, and also this oblique key wire, which direct you the oblique screw. This is the small knife. This is the burr system, and that's all. And this is the way it comes now, the plate. So we have the C-arm. Under the C-arm, I mark my position of the plate. I know where I would like to be with my osteotomy, and I would like to be as much as possible proximal, so I have a high potential of correction. And also in the proximal part of the bone, at the metatarsal bone, there is more cancellous bone, so better bony healing. So this is my osteotomy is already done. In this case, I did a perpendicular. You also can do a more oblique. In this case, I did it perpendicular because I wanted to do a rotation correction also. Sometimes you break the hinge. Usually this is a problem, but if you use a plate, you will get a new hinge. So with this plate, it's not so a big problem to break the hinge. You can stabilize it with the plate. So now the osteotomy is done. It's fixed from the first metatarsal to the second. And through this incision, I'm bringing in the plate. Okay, as far as you see. If you do that, you have to be in your mind that the first metatarsal bone is plantarized. It's running plantar. So you have to check it really under fluoroscope that your plate is right in a good position. But introducing it from proximal with this guide, it's not so hard. The next thing is bring in the oblique key wire. I fix it with the drill guides. This is the distal holds me the correction, and the oblique key wire should end up at the lateral proximal part of the metatarsal bone. This is the area where later your oblique screw is running. So you start with the distal hole, just a locking screw through this guide. After that, you bring in the oblique screw. It's all this one is a non-locking screw, so we have compression at your osteotomy. After that, you bring in your 2 screws to block the plate. So just at that time, if you have this X-ray, the whole operation is nearly done. You have your correction, you have your plate on the right place, and the key wire is at that area for your compression. The next part, bringing in the screws, it's not a big thing. And then you will end up like that. You can add another Aiken osteotomy and an MIS technique, or do another osteotomies if you would like. But the main thing is to bring in the plate, do the osteotomy in before, and to get compression on your osteotomy. Post-op is 6-week full weight bearing in a stiff sole. I use those tapes, then nearly the same thing that kinesio tapes, so I can stabilize the first ray or second ray if you need it, and there's no big dressing, and you can leave them at least 3 weeks. This is the case we already have seen. This is this 44-year lady. I did additional DMMOs and osteotomy of the 5th ray, a little bit too much bone resection here, but 6 weeks post-op, it's okay, good wound healing and a right first ray. Another case, 48 lady, and this is 3 days post-op. You see the small incision here. This is for the distal screws. This was the incision for the bringing in the plate. And this is for the Aiken osteotomy and for the Aiken screw. That's all. That's all you need for this technique. And post-op, these tapes with some kind of plaster on it. This is 6 weeks post-operative, good bony healing, good compression, and a good alignment of the first ray. And this is what I like to see. This is a good post-op movement. We don't have a real stiffness on the first metatarsal joint, metatarsophalangeal joint, and the alignment is good, and we have not, in this case, no real stiffness. Going back to this slide, the weak stabilization, less weight bearing, longer rehab, I don't see it in those patients. We don't have this plate, we don't have the Holy Grail or something real miracle. We only have combined the benefits of this open surgery technique with the locking plate, big and strong stabilization of the osteotomy, and a fast rehab of for the patients. And the good thing of the MIS surgery, less swelling, less pain, less stiffness. So I think it's just a combination of two things that we know. So it's not a big thing, and it's reliable. We have a good drill guide where we can bring in the plate in the right position, and we are not forced to find 2 screws, 3 screws in a way to fix them. So I like it as far as I have now my experience. Thank you. Good. Arthur, you're on.
Yeah, thank you very much. It was.
I forgot to mention Steffen. He is also part of the group, and he took really a big part in moderating us and bring us together in this project. Thank you, Steffen.
Yeah, you're welcome. Thank you, Hazi. So, very, very nice presentation, and it helps, I think, everybody who's on board here. So we have around 80 people now listening to better understand your principles and your ideas behind that system. So I can imagine there are some questions coming from the audience. So let us check what's written here. So what is your ideal indication to do this procedure?
I think it makes no sense to do this operation if you couldn't do it a minimal in the MIS chevron. For me, this is a nice indication to do in patients more than 15 degrees intermetatarsal angle. So I would like to do MIS, but I don't like to do a lapidus in those cases, or a scarf, big incision scarf. So this is a good thing for those patients. If I have less than 14 degrees or 15 degrees, I do a MIS chevron. Again, a good technique, MIS, normal MIS chevron with a good bone contact, not a full displacement of the head. This is not more necessary. So my indication is more than 14, 15 degrees intermetatarsal angle.
Okay. Somebody else is asking, do you have any concerns about skin burns or skin irritations, doing everything percutaneously or from outside?
I think this is mainly a big problem, a big question always in MIS surgery. So it's not a typical thing for this technique. If you take care about in every year MIS techniques, I don't see those problems. it's only one cut with the burr. So you have to use irrigation, and it's not so big problem. You can you skip. It's no need for tourniquet. You don't need tourniquet in those cases. So additional fluid is there. I don't see a typical problem for that plate. No.
A good question was coming in from Jonathan. He asked if you ever had any problems with elevation of the first metatarsal head due to the orientation of the hinge.
Yeah, it's a good question. I try to address this with this key wire where I put this from the first metatarsal head or the first metatarsal to the second. If you bring in this key wire, you find you don't have an elevation problem. And if you have if your hinge is your problem and did an elevation for you, cut it. It's easy to say, but if you bring in a plate and you fixate, you bring it in a plate as a hinge, it's okay. You stabilize it. If you use the old proximal, not all, but the known one screw technique with the proximal osteotomy, and you have to protect your hinge, but your hinge is bringing in you in elevation. It's a problem, yeah.
Frank Mattes, you know him, he was asking if you can do an open wedge osteotomy with the same system.
Should work. I think it should work. Why not? It's nothing new. We know locking plates. If you change your technique, why not? I don't see a reason why not. It's up to you if you need to bring in the gap something. I don't know if it's necessary. I cannot say how much correction you would like to do and how much is your gap after doing an open. But the typical technique of locking plates, why not? I don't see the problem by the plate. It's just the operative technique of the osteotomy.
And also a very good question from Stefan Pfeiler coming in. If you ever had any problems with the parser after the correction at the base, so have you ever had to do a distal correction as well?
Not so far. This is the mainly thing that we say, if you do a proximal osteotomy and you have a pathology in the parser, it doesn't matter if you do a lapidus or a proximal osteotomy, usually the parser stays. But in the last years, we heard about and learned a lot about the derotation of the distal part. If you break the hinge and you performed, as I showed you, a total osteotomy of the metatarsal, you're able to do a rotation, and by this, you can correct the parser like we do it in the lapidus arthrodesis. So far, I was not forced to do an distal additional osteotomy. I do Akins, yes, but no distal metatarsal osteotomy. I do a derotation. You can address this by derotation.
And Jonathan is asking, what about the sesamoids? If you do the final fluoro check and you still see a displacement of the sesamoids, what is your next step then?
You do the soft tissue release at the end of the operation. So when I start to do foot ankle surgery, I always did lateral release, and then we did the osteotomies, and then we do the shrinking of the capsular. But now I change. I do the bony part, and if it's still not fine, then I do the lateral release. So I do them. I go for the lateral release at the end, and to try to address the sesamoids by that, if it's still pathologic there.
Perfect. Okay, so I don't see any more questions in the list. So
I think we can let our email address and just maybe put some surgeon in touch with Adzi to yeah.
It's a new technique. We just started. Can you just send me pictures, X-rays if you start. I would be happy to see your cases and to learn with you. It's not my technique. It's just bringing in two well-known things of MIS surgery and locking plates together.
One question came in.
Technique or something else. Just send me your pictures. I would be glad to see it.
Steve is questioning, is asking about the non-union rate. It's probably too early to say, right? So it's.
Till now, I don't have a non-union, but I cannot say anything. You have to be careful with your burr. Don't try to do a high speed. I think this is one goal. Like in every MIS level, be careful with the burr and take your time with the X-ray so you can check the right plate position and good screw position. Till now, no non-union.
Challenging question from my side. Would you do a Lapidus with that system?
You remember our first lab?
Yeah.
We did our first lab without a C-arm, and I thought I'm doing a proximal osteotomy, but I did a Lapidus. I was too far proximal. I recognized it at the time when we opened and wanted to check the position of the plate. So because of that, I think it's possible. Why not? Because we did it already, but I'm not sure about taking off the cartilage if it's possible. If you do it, send me the pictures. I would be glad to see it. From the technical part, yes, the normal proximal Lapidus plate, why not? It should work. We have locking plate with the compression. So it should work from the technical part.
We have another question from Carlos Menendez from Spain. Would you like to do a closing wedge osteotomy? So this technique, if you have a short first met?
I think the main thing what I recognize is I don't have shortening by that. So if you have a short one, don't use other techniques where you have definitely a shortening. And we're going back to the first question of the open surgery by Frank Mattis, I think, was it? Yeah, you can try it. You can try it. Why not? But at least you don't have more shortening than in other techniques. So if you try to use an open technique and you're brave to do a gap, it should go up. We know it from the distal tibia and other places, it should work. And this technique is more benefit. There's more benefit for avoiding an additional shortening. Yeah.
Okay, great.
Thank you.
Thank you so much. Thank you very much, Adzi. It was a very great presentation. I will let my email address, so let's see, maybe we will have more questions later. But yeah, thank you to everyone, and thank you very much, Adzi, Stefan, for everything.
Thank you.
Thank you.
And as soon as we are able to travel again, I think you are happy to host your colleagues from Europe or from all over the world to watch some surgeries, right?
I would be glad to travel to the south of Europe.
Okay. Thank you. Bye-bye from Germany.
Bye.
Bye.